Thank you everybody for joining us, and I'm going to turn it over to Angie LaFlamme to introduce our speakers for today's presentation.
Thank you, Kiona. Welcome everyone to our webinar today. I'm really excited to introduce our four speakers. First, we have Joyce Villeneuve. Joyce has over 30 years experience with the within the private sector, assisting health plan payers and providers on how to utilize technology, clinical auditing, and medical management to address areas of concern within reimbursement, quality, and risk adjustment. She joined the Indiana State Department of Health as a state rural health manager in July 2019, and in this role, she also oversees the SHIP grants. Her degree is a Bachelor's of Science in Business Administration. And co-presenting with Joyce is Shelby Hull. Shelby is the Rural Health Project Coordinator with the Indiana Hospital Association. Over the past 2.5 years, she has had the pleasure of supporting Indiana's rural and critical access hospitals in various capacities, including the Small Rural Hospital Improvement Grant. She's previously worked with grants focusing on hospital quality outcomes and infant maternal health. Shelby is a graduate of the Indiana University Fairbanks School of Public Health, holding a Master's of Public Health in Health Policy and Management. We also have with us today, and Lima, I am just going to butcher your last name, so I'm going to give it a shot, but correct me if I'm wrong. Lima, I don't even want to try Lima.
Etchigoyen.
Etchigoyen. Lima Etchigoyen. Lima is the Outreach and Technical Assistance Coordinator at the Office of Statewide Initiatives at the University of Nevada, Reno School of Medicine. Lima graduated from the University of Nevada with a master's degree in public health, and she's been with the Office of Statewide Initiatives since 2014, and in 2018 became the Nevada SHIP Program Coordinator. And Lima's co-pilot today is Becky Bailey. She is the Director of Strategic Initiatives for Nevada Rural Hospital Partners. That is a consortium of critical access hospitals in Nevada. Becky earned her master's degree in business administration from the University of Nevada, Reno. And Becky's been with the Nevada Rural Hospital Partners for 14 years and has been working on the SHIP program for the last 12 years. So thank you all so much for giving of your time to share with us today the innovative ways that you all are taking to approach delivering education.
Before we get started, I'm going to pull up the quick polling questions so we can gather where you guys are at before the presentation starts on your knowledge on this innovative ways to share training and education. So if you'd please take a moment to select where you currently feel you're at. So extremely confident, confident, moderately familiar, slightly, and then unfamiliar. I'm just going to give about 30 seconds. Lima, are you guys going to kick us off today? You can share your screen with us.
Okay, thank you.
You're welcome.
Can you see my presentation?
We
my
can.
PowerPoint? Okay, perfect. So, hello, my name is Lima, and I am SHIP and Flex Program Coordinator. And Becky is joining me today to share about the SHIP program in Nevada. Becky's with the Nevada Rural Hospital Partners. They have been the primary subcontractor for SHIP, for the SHIP and Flex programs for about almost 20 years. First, I wanted to start with a short introduction to Nevada. Nevada is the 7th largest state in the United States with a relatively small population number for its landmass. Nevada has 17 counties, of which 3 are urban, 3 rural, and 11 frontier counties. Nevada has 14 rural hospitals, of which 13 qualify and participate in the SHIP program. Each square on the map that you see on the PowerPoint represents critical access hospital. This map also shows the vast distances between rural and frontier towns in Nevada. The average distance between rural hospital and urban hospital is a little over 100 miles, and the average distance between rural hospital and the Nevada Office of Rural Health in Reno is about 230 miles. Also, Nevada has many mountain ranges with difficult terrain, and this makes traveling challenging, especially in wintertime. And considering these distances, the SHIP program has a very good attendance at its in-person quarterly meetings with multiple work groups and regular site visits. And of course, at this moment, in-person meetings are disrupted by the COVID-19 pandemic. The meetings are continuing using video conferencing, and we had a seamless transition to online meetings because we have already had a Zoom communication in place. So the next slide is Nevada SHIP program framework. The big part of Nevada SHIP program success is attributed to critical access hospitals working together as a group. We adopted from the very beginning of the SHIP program a consortium approach to best utilize SHIP grant dollars. As I mentioned before, Nevada Rural Hospital Partners has been subcontracted by the Nevada Office of Rural Health to administer SHIP supported activities and to coordinate the SHIP consortium. The consortium consists of 12 rural hospitals. These hospitals combine grant funds to maximize program value by negotiating group rates to purchase information technology and vendor services such as HCAHPS surveys. I also want to mention that the Nevada Office of Rural Health and the Nevada Rural Hospital Partners have been closely coordinating SHIP supported activities with flex supported quality performance improvement projects to complement both programs without duplication of efforts. Nevada SHIP program main activities consist of work groups, site visits, technical assistance, and registration for education courses and Western Region Flex Conference. The next slide lists all of the work groups that we currently have. The work groups usually meet on quarterly basis, and if necessary, the work groups are created to target a specific area. The frequency of group meetings can also change as needed. For example, since April, the infectious control group work has been meeting using video conference weekly to address the newest information on COVID-19. And this is our work group activities. Some work groups some work group activities slightly changed since a travel ban, but usually work group activities start with sharing news and issues that come up since the last meeting. And SHIP Consortium is a not judgmental place where peers feel comfortable to share their successes and failures. There's a friendly competition on MBQuip scoring, but no competition for clients. Our rural hospitals are so far, they are so far apart that there's no out migration from one rural hospital to another. There's more concern on patient out migration from rural to urban hospitals. After the sharing the news and issues, there comes up another part of the meeting, which is expert consultants lead education and training part of the meeting. And the same consultants provide support to consortium members even beyond the meetings. Consultants and consortium members know each other for a long time, for years, and they feel really comfortable reaching out and asking for help if needed. Other speakers are invited to work groups as needed. Often state officials join our meetings. For example, we have a good relationship with the state EMS office. And the data visualization is used through the meeting, and Becky will further on share examples of the MBQuip data tables and graphs. Becky, you ready?
Sure, okay, can everyone hear me okay? Thanks, Lima. Okay, so Lima talked about some of the really important things we do as far as bringing the peers together. And obviously before the pandemic, we liked to bring them in person. We felt that that was a really good way for people to network and make friends when they would otherwise feel kind of isolated out there on their own. So we bring them together, and then we also have one consultant that goes out and does the site visits. And we really feel like this, those two things together help us to learn what types of education these guys need. So now onto our data visualization. This is actually a very, very simple chart that I put together in Excel because what we learned was people needed something that was easy to see at a glance. And so this has nothing to do with performance, it's just reporting compliance. And I think that little H caps in the bottom there is just, we didn't have that one back yet, but you can kind of see here how we had the hospital in the bottom right there was kind of in the red. They just weren't reporting on anything. But you can see the improvement as they get more and more green. And so what we did with this actually is we brought it to the CEO groups. And so we have two CEO level meetings. One is the NRHP board meetings, and one is LICON, and I'll explain that to you in just a moment. But what we found was the CEOs often had no idea how they were doing on this. So this simple act of just bringing this to their attention and an easy to use visualization. And the other part of it, honestly, was a little bit of competition. So nobody likes to have the bad box. So that actually really, really helped us. The other thing we learned from this was folks were telling us that one of the most difficult parts for them was maintaining the CART software. They're only in there every couple of months. They're not the expert on this. They have just this little bit of data to put in there, and so they kind of forget what they're doing. And so we took the initiative to create what we call the CART servers here at NRHP, and our Chief Information Officer, he keeps those updated and maintained, and they never have to worry about having to do the updates on those, which actually helped a huge amount and has allowed them to report on time more often. So that was one of the ways we just kind of learned. Sometimes you can offer them education, and sometimes you can just take a little piece of it away from them, and that helps a lot. Lima, can you go to the next slide?
Mm-hmm.
So this is graphs that we created with Tableau, and I think it's this slide and the next one. So this one is going to show you, this is one hospital's graph on how they did overall on HCAHPS for that quarter. So it has each of the survey questions in there. So it's kind of an at-a-glance thing with how did you do, where are you bad at? One of the things that always seems to be a low score is that response rate. So we work on that a lot. And Laima, if you could go to the next slide. This is where we really find a lot of value, is when we look at one question, whether it's HCAHPS or some other part of NBQIP, but we have all of the hospitals, and here they're de-identified, but in our meetings we go over them identified. And this will allow us to say, gosh, you know, we really don't have a lot of green on the quietness measure. And because of that, we started doing more education around quietness, looked at how other hospitals were addressing that issue. And we actually purchased noise meters to put in the facilities to see if that would help us to get that measure up. Next slide, Laima. So the impact of this really is we feel like what we do is we reduce the burden on individual hospitals, whether that's through providing education or just listening and finding out what we can do to make their lives a little bit easier. We feel that it's easier for individuals to acclimate to a new position when there's turnover, if they have the groups to come into, they get that education. Sometimes we find ways just to support, I'll give you an example. We have a new IP at one of the hospitals, and so we are supporting her APIC courses to get her up to speed on that. We feel that there's better communication among various groups. So for example, what the quality group already knew, we want to get that to where the CEO group understands that as well. Because we find a lot of the times there's not very good communication within the hospital. And then mentorship, a lot of times a senior quality director in one hospital can mentor, you know, or really any position, risk managers, HR, you know, we find this all over the place. And so we just feel like they have less of a feeling of isolation when they have these groups to come into and educational opportunities to sort of rely on us for. Next slide, Laima. So how do we measure success? So obviously meeting attendance, NBQIP performance, participation, compliance, and then NBQIP performance are things that probably all of us measure a lot. One thing I wanted to mention really quickly, and this is not a SHIP activity, obviously, but LICON is the Liability Cooperative of Nevada, and it's a liability pool. And we have something called the DMV model, which is, it actually stands for the Department of Motor Vehicles, and the intent is to sort of have a reward system for what we call good behavior. And the reason this is a LICON initiative instead of a grant initiative is because LICON's been around since 1989, and we've been doing this for a while. But this is sort of just a checklist of, you know, did somebody attend the quarterly quality meetings? Did somebody attend the quarterly infection control meetings? And so the more points they get for that, they get an actual reward check back at the end of the year. And so when we talk about things that can be replicated, I really think that's something that could be replicated under the SHIP model just as much as we're doing it under our liability pool. Other things, the work groups, meetings in different areas, encouragement of peer support and networking, communication among the groups and background to the CEO level is very important. The use of the expert consultants, tailored trainings based on member feedback, and some of the time these are in group settings, and some of the time we actually take those to the hospital itself. Those site visits for a deep dive at each hospital. Laima mentioned the use of complementary funding streams if possible. We also have a foundation, and if we can't figure out how to support education any other way, we will use that foundation funding for that. The incentive scorecard and the rewards, which we call the DMV model, feedback that's easy to interpret and that is meaningful to the members. And then the last thing is always just listening to the members and being responsive to them. And that's all I have.
Thanks, Becky. We have a couple of questions from the chat. Let's see, where was the first one? I think.
Do you want me to stop sharing?
Sure, you could, yeah. So Lima and Becky, Jill Bullock asks if you could elaborate a bit on your cart service or cart servers.
Sure. So I don't know if I can elaborate too much because it's in the IT realm, which is a little above my head. But our IT person here, Todd, he created a server for each hospital that only they can log into. And the thing that took us a really long time to figure out was how to get Lima, do you remember what it's called? The little two-factor authentication thing that it takes to log into QualityNet. So what we do is we have the CART software physically downloaded on that server, and then they have a link to QualityNet. And the difficult thing was making sure they had their little two-factor authentication, and that I'm blanking on the name of that, but so that it was all in one place. So they didn't have to get their data out of CART back to their computer to use that login to QualityNet. So we just got that all on one server, but the most important thing is that Todd does all of the updates because I'm not sure why, but it seemed like every time people at our facilities were trying to update CART, something was going wrong and then they missed the deadline. So I'm not sure if that answers your question, but if you want more information on it, I could definitely get that from Todd.
Thanks, Becky.
Great. We've got another one. Do you have a link with more details about the Lycon DMV model?
I don't, but if anybody, I'll type my email address into the chat box here. And if anybody wants to see what we have on that checklist, you're more than welcome to shoot me an email and I can send that to you.
Great. And then the last one, Don says, love the point system. Can SHIP funds be used for the incentive point?
You know, I thought I had brought it up in this meeting because I thought I heard somebody on another webinar at some point discussing utilizing funds based somehow on it was either MBQuip participation or performance.
Great, thank you. Any other questions right now for Becky or Lima?
Oh, hi, this is Dorothy from New York State. I just had a question that would be easier to just ask this versus typing it. So when your rural hospitals got together and worked in a consortium, did they see significant savings by negotiating group rates for things like software versus when they did that individually?
Becky?
Yeah, so yes, we did, especially one of the biggest things was with HCAPS. So I don't know if anybody here was with HealthStream when they were bought out or that division was bought out. And so we kind of all went to Press Ganey, and the worst part of it was Press Ganey kind of came in and started changing their contracts and charging them more, even though their old contract should have still been in place. And so what we did was found a new vendor and negotiated much lower pricing, and actually also negotiated for that vendor, they're called JL Morgan, to go to each facility to train them in person.
Okay, so was JL Morgan the, like helped collect the HCAPS data in addition to training?
Yes, they are the HCAPS vendor, but they agreed to go out to every facility and help train them just on HCAPS score improvement, which we found was of great value to going with that vendor.
Okay, thank you.
We've got one more question from Sherry Wyatt. Do you have the consortium agreement that all the hospitals signed?
Yes, is that something you wanted us to share? We have each hospital sign an agreement every year.
Great. All right, seeing or hearing nothing else, we will move to Joyce and Shelby. And if any other questions come to your mind for Lima and Becky, we'll have a little bit of time at the end for some additional Q&A.
Good afternoon, everyone. I'm Joyce Fellenworth, and as shared, I'm the State Office Rural Health Manager. And myself and Shelby Hall from our Indiana Hospital Association are going to share with you what our SHIP program looks like. So I'm going to take myself off video so I can present this for you. Our program actually began in 2018. And Shelby can go ahead and go to the next slide. We have been, our SHIP program had been off the format of being a direct disbursement program to the hospitals, and we really wanted to transform that more into the educational training model. So in 2018, we reached out to our hospital association, who we had a great relationship with, to see if they would be interested in helping us develop such a model. So we started by doing really just informal focus group surveys to our hospitals to see what type of programs would you really be interested in participating. And Shelby, go ahead in the next one. So in 2018, from the information that we obtained from the hospitals, there were really, we decided we would go with 6 projects. And they focused in the areas of coding, reimbursement, simulation training, violence in the workplace, transitional care, and IRS 501. And in that original pilot program, we told the hospitals that there was no limit on the number of hospitals that, or rather the number of programs that they could participate in, anything from 1 to all 6. What we quickly learned from that offering is that the hospitals were very eager to do everything, but soon became very overwhelmed. They struggled with being able to complete all the projects. So we obviously soon learned that we needed to streamline that program somewhat. So the following year, in the grant year that just ended of 2019 to 2020, we streamlined that back to 4 educational programs. And we shared with the hospitals that how it would work is that each grant year cycle, they would choose one program that they wanted to participate in, and that throughout each grant year cycle, they would rotate through our 4 programs. They then had the option to add on our special innovation project in that first year. So this past year, what they would do is that they would rank our 4 programs through their hospital assessment of which had their highest interest by 1 through 4. We would then develop those cohorts, and then they would share with us, do you want to participate in the special innovation project, keeping in mind this will be a second project, and this is a 4-year commitment. So once you're in, you're going to stay in this project throughout the entire grant year. You can't jump in year 2 or 3. It was a first-year commitment. Go ahead, Shelby, to the next slide. So the hospitals, we looked at their community health needs assessments. And from that information, these are the 4 programs that we streamlined to offer. The patient and family experience, being able to maximize reimbursement in an outpatient setting, simulation training, and mental health with a focus on suicide. So again, through their applications, we list those 4 programs, and then they rank those from 1 to 4 of what their highest interest would be. And from there, we developed our cohorts for each of the projects. Last year, in the grant year that ended in May, we had 30 hospitals participating. This year, we have 32 hospitals participating, with 24 of those being critical access hospitals. Go ahead, Shelby, to the next slide. So then we have everyone enrolled in the program they're going to participate in. And then each of our project leaders who are going to lead each individual project, they devise a work plan that is going to apply to all their hospitals and for their project. But what we do is that they'll have what they're going to do on site, how many on-site meetings they're going to do. Obviously, in today's world, it's become more virtual. The kickoff assessment, how many webinars, and etc. But that's kind of the general plan. Then what we do, though, is that we go on and we have our kickoff meeting with the hospital. And with the project they've chosen, we sit down and we do an assessment with them. And we further define within this project, for example, like with simulation. What is the area, what type of simulation training do you need? Well, we want sepsis. Why do you want sepsis? What impact, why do you feel that's a need? And what do you want to gain from this? And from there, we put together what steps that they need to put in place in order to fill that gap and obtain that goal. And within, and then the format is that we provide, again, we last year did much more on-site visits, but we're starting off doing more virtual. But we do at least bi-weekly, if not monthly, calls with them. One, for obviously accountability. Two, to make sure that we are keeping them involved in what steps they need to be taking. What are their obstacles they're incurring? What technical assistance do they need from us? What support? What ideas? So we act almost like as a consultant and making sure that they're going to obtain what they need out of this program. And then at a higher level, at the cohort level of each project, we do activities such as webinars and conferences with individual follow-ups to that as well, to make sure all the questions that were answered, what are they going to take from that information? What else can we do to enhance what they're trying to obtain, again, with the objective of the program? Go ahead, Shelby, next slide. Obviously, as I shared with you, this format that we currently have in place, the first year of it just ended in May of this year. And halfway through, as we all know, COVID surfaced. And that obviously did impact our programs with, all of our hospitals going full steam ahead, and then bang, COVID hits. And now they're trying to deal with the pandemic, but yet how do they keep these projects going? So obviously it has been a struggle, but they're still very excited about it. They were still putting forth all the effort that they possibly could to dedicate to these projects. When we sit down and discuss with them the outcomes and so forth, this is still a work in progress to really further define what it is they want to get out of these projects, what's the gaps they want to fill. So we are constantly working on how we can really fine tune that and pull that out of them. And then having COVID hit just obviously put some obstacles involved with obtaining those goals. But despite even all of that, there are a couple of highlights that I just want to show you, that no matter what comes along, is that you can still be successful. And with the simulation training, there was actually a hospital that in their kickoff assessment with that SHIP team member had shared that there had been a couple isolated issues that they felt their staff really had failed to recognize patients that were deteriorating prior to cardiac arrest. And they did not have a rapid response team in place. They had very limited staffing, and they just didn't know what to do. So the simulation project leaders went in, they worked with them through simulation, and they identified with them what pressing gaps really there might be, helped them develop procedures to put in place, even with limited staffing, so that they would be successful and much more, and improve much more the quality of the care of those types of patients in those situations. We also had, with our patient family education, a hospital that wanted to really raise their ratings. They were at a 4 and they had a goal to get to a 5, wasn't sure how to do that. So our project team leader of the SHIP team went with them and focused on how do they develop a patient advisory council, who are the people that they pull in to do that, how can they really, the importance of bedside shift reports, how can they do that so the patient is understanding what is being said and family members, and also how do you increase morale of staff. So those were the focuses, and they did actually just share with us that their star rating went from a 4 to a 5 and really felt that the input of the SHIP program made that possible. Within outpatient reimbursement, we had a hospital who really had a very poor % of people coming in for annual wellness exams pre-COVID. And so the SHIP team later went and kind of looked over their processes and procedures, found out there really wasn't any, and helped that office put together steps to identify those candidates, put together a way to do a like an outreach so they could make those appointments with people on the phone and through text and so forth. And in the first month of getting that program in place, they did increase their visits by 25% in the first month. And then the last one was zero suicide. The couple things that evolved out of this project were really tools to help the hospitals and moving forward. We put together like a workforce survey that they would send out to their staff. So the executive leadership could really see where the gaps were in the comfort level of the staff felt in dealing with those situations, especially through an ER environment. One of the hospitals actually brought in their local law enforcement to sit down and talk to them about, you know, the data they're seeing on their visits, the data that's coming to the ER, and really started to work to involve to create a partnership between law enforcement and the ER department. And then the hospital association worked with our hospitals through their claims data and actually created a dashboard report that they could compare themselves statewide within counties, and also demographic information on the breakdown of suicidal attempts that are occurring. So those are the successes that even again, in our first year of doing this program and with COVID, just to share with you is that, you know, success can come out of when you think like nothing may be happening, success will show itself. And moving forward with our core SHIP program, we obviously want to continue to build on success. Obviously COVID's not going to go away tomorrow. So we realize we need to continue to maintain flexibility and adjust to these environmental changes. We're thinking, how can we still have the impact that we did with people face to face in this virtual environment? Even looking at how many hours do we take away from their day, really trying to tweak our outreach to them so our program can continue to be accessed to the time that they're developing or devoting to this program. So at this point, I'm going to turn it over to Shelby, and she's going to talk to you about our Special Innovation Project.
Great, wonderful, and thank you so much, Joyce. Yes, I'm Shelby Hull with the Indiana Hospital Association and have the great pleasure of working with Joyce in the State Office of Rural Health with the Indiana Department of Health. We thought it would be great just really to pull out kind of our very unique project that we've evolved over the last kind of few years and really kicked off, of course, last year. Of course, we've had a vision, as I know every state has with their SHIP program, and this one is definitely evolving and something we're very proud of for all that is to come as well. So that is the Special Innovation Project. We're really focusing, as you can see, on advancing the health of Hoosiers in rural Indiana by focusing on hospital community health needs assessments. And some of those assessments are actually put forth with their community partners as well. So sometimes it might not be a hospital specific assessment, but a community assessment. And again, our goal really over the next 4 years, now 3 as we're in year 2 here with our hospitals, is really to focus on their needs and their specific needs as a rural community. It may differ from another hospital, you know, across the state. We do cover all 4 corners pretty much of the great state of Indiana, but also really how they connect. And we know our rural communities are facing very similar issues right now. So in year one, last year, so in 2019, the Hospital Association, along with the State Office of Rural Health, we conducted a kind of a first initial conversation with each of our 15 participating hospitals. So we would really do kind of an audit, so to speak, of their community health needs assessment, just their most recent one, which happened to be about 2018, which worked out well. And really, again, we mapped out, as you can see on the little pie graph, we had two big glaring rural health kind of concerns, if you will, which is substance use disorder and mental health. And I'm sure every state can really relate to that in every rural community. So again, we did not determine that hospitals needed to work on substance use disorder, mental health, diabetes, tobacco, and access to food. It was really what they brought to us. And that is what they spoke to us that said that was their concern and what they wanted to focus on. So the hospitals can choose 1 to 2, but again, they really kind of focused on 1. We've noticed a lot of hospitals, if they want to focus on substance use disorder, that mental health aspect really ties in well. So again, we did kind of an audit of that, really focused on what they've been doing in the past versus what they want to move for in the future. Some of our hospitals are really innovative and they have work groups for different components they pull from their needs assessment. So we've been working with those groups as well, really supporting their community and supporting their work moving forward. So again, that was year 1, really just building that framework and that roadmap to really focus on for the next 3 years. So as we begin this year 2, we're only a couple weeks in, but it is already September tomorrow. One of the big focuses we want to move forward is health equity and Z codes, along with the social determinants of health. And this was the big goal when Indiana really came together and said, we want to do this special innovation project, and this is our main goal. And we've actually heard from a lot of our communities, they want to focus on that health equity, especially in those communities. So we actually have a 5 webinar series. They were supposed to be in person, but we're all very fluid and flexible during these times. So we have moved those virtual, and we did host our first webinar last week. Great attendance. Our hospitals are really geared up to go. And these are our next 4 webinars, as you can see here. We're excited. Our next kind of series, really, we're partnering with the Institute for Diversity and Health Equity, really to focus on those partnerships and cross-sector collaborations amongst our hospitals, amongst different organizations, federal, state level, community level. We're going to work with the hospitals to really create a team with the registration staff, their CMOs, their HIM teams, and we're going to have some Indiana hospitals. We actually have a few, one being rural but not SHIP eligible, and then one being a larger hospital in the state that's really kind of ahead of the game in this work. So we'll be working with them to really share what they've done in their organizations. And then we're going to help identify a system baseline for the social determinants of health. And this is how we're going to focus on our health outcomes moving forward and really focus on that data aspect. And I have to give a big shout out, they're not on the call, but of course, Matt Browning and Ryan Prentice and the entire IHA Data team for all their hard work. They've created a dashboard, and I'll show you on the next slide, that we'll be using to really evaluate those Z codes, those social determinants of health, and how we're tracking. And then in the end, we're going to build a process that really impacts hospital performance. So this is not a 1-year project. This is, 3 years and further. So really sustainable and really supporting the hospitals, meeting them where they are, and really moving forward with them and not doing a one-stop shop. So as I kind of promised, this is the IHA Data Link platform, and I talked with the team before I shared this, and they were excited to get this out here. It was recently updated, which is wonderful. So this will be updated more. Again, we're just starting with this, so this is going to build and grow and become really what we focus this project around. But at the top of your screen, you can see Z code groupings by year. So there are a few Z codes that are pulled out now. Again, we can add more as we move forward with this project. But really, you can kind of see based on the shading where those Z codes are tracked in the state of Indiana amongst all of our 92 counties. And then at the bottom of your screen, it really breaks down by quarter how many Z codes were tagged within each quarter amongst those different Z codes. Again, this is a work in progress. We're just now beginning, so we'll be tying this directly to what the hospitals, what Z codes they will be using and what Z codes they'll be tracking as part of this project. So just a little teaser, but there will be a lot more to come with this, and we're really excited and thankful for the data team at IHA. The other big thing we're doing this year, again, as feedback from our hospitals, we're doing a free grant writing workshop. Again, supposed to be in person, but we're very fluid. So tomorrow actually is our fourth webinar series on writing a strong proposal. Really, we've heard a lot of hospitals, and I'm sure you all in your communities as well, a lot of hospitals are wanting to apply for those smaller community grants or even larger federal grants. We have some hospitals, you know, that are going larger. But we found that we really want to support these type hospitals because as they determine kind of a focus area from their needs assessment, there's a lot of grant opportunities moving forward from there that they can apply for. So we're really building that formation for them. Every hospital is actually coming out of this grant workshop series with a grant proposal ready to go. So just to kind of filter that for whatever grant they're interested in applying for. Overall, in Indiana, we're not reinventing the wheel. We're really supporting our hospitals in every way that they've identified to us as an association and to the State Office of Rural Health. Really, we just advise everyone just obviously listen to the feedback from your hospitals. They know their communities and populations best. And although we support them in every way, they still are the ones that are able to say what they need as a community. And we feel we've done a great job over the last few years of really getting that feedback and really putting this project in the hands of our hospitals. And then of course, just in Indiana, we really just want to make sure these projects are meaningful, impactful, and sustainable. We're not a one-stop shop. We really want to get the work moving, and we're excited for the next 3 years and more with these hospitals. So with that, Joyce and I's contact information is on the screen. I know there might be a few questions as well, so I can stop sharing and we can run through questions.
Thank you, Shelby. Not a question necessarily, but John Olson from Vermont says he'd be interested in any information you can share about the Institute for Diversity series and that they're pursuing something similar out there. So he put his email in the chat box.
Wonderful. Yeah, John, I'll write down your email and we can definitely connect on that. And again, don't want to reinvent the wheel and want to support each other. So thank you so much, John.
Do we have any other questions for Joyce or Shelby or Lima or Becky?
And I do see Rebecca may have mentioned something about the suicide program. So Rebecca, if you do want to share your email address, we can definitely connect as well.
I have a question for all of you. I'm assuming that you all are using virtual formats right now for delivering your education. Do you feel like your participation, the level of participation has increased or has it decreased?
I think in some ways it has, Shelby, would you agree, increase? And then sometimes I think we see where there's been a decrease. I think it depends, and this is what we're still evaluating, the time commitment when you do it virtual. Does it work if you, what would normally be like a full day conference, do you break that out in an hour or two, or do you go for like 4-hour increments? And I think with COVID and kind of the ups and downs that the hospitals are seeing as far as how that's impacting them has made an impact on the number of participants that we have.
Yeah, and I would second guess. I think Joyce did a great job representing Indiana there. But I also think, you know, with our rural communities, as most states, there are, you know, pockets that are experiencing COVID in different ways, whether, you know, their case numbers, you know, seem low, but to them it's very high. So I think we really are just trying to be very respectful that every hospital and every community is in a very different situation, and really understanding that with our programming and the timing of that programming. But I do think our hospitals are excited to do something different that's not COVID related and really get out there and do something meaningful for their community.
Well, with that, we would like to thank everybody for their attendance today. and to our speakers for sharing such a great information. Before we close up, I have a few polling questions that I would like to ask. And again, we had initially asked concerning my knowledge of innovation approaches to delivering training and education. At the beginning, I'm going to ask the very same question. And if you guys could please share your level of knowledge now after the presentations, we would greatly appreciate that. I'm just going to take a few seconds to do this one, as we do have a few following poll questions to ask as well. I'll give about 30 more seconds. Wonderful, thank you. Additionally, we would like to ask if this webinar increased your awareness of innovative approaches to delivering training and education. I will give just a few more seconds for this question. Additionally, this webinar topic was relevant to my SHIP needs for the future. And I would just like to share again, we greatly appreciate the feedback that you guys provide for us. It just helps us with topic selections for events, also knowing if what we have selected is relevant and appropriate. And then also just feedback that's provided on ways to improve on future events as well. And I have one final question to ask you today before we close up. So overall, I'm satisfied with this webinar event. And before we close up, I just want to pull up perhaps Andy, if you want to just quick pop on if your audio works this time to say hello and introduce yourself to everybody, as you will be the new SHIP coordinator on our team.
Hey, Kiona, can you hear me?
I can.
Hey, thanks. Yeah, sorry about the technical difficulties earlier, everyone. Just wanted to say hello. Like Kiona said, I'm Andrew Naslin. I'm taking a program coordinator role for the SHIP team. I recognize a lot of you from Flex and the participant list, so it'll be nice working with you here as well. And I'm looking forward to meeting some other new folks as well. So thanks, Kiona.
Thanks, Andy. As we wrap up, I just want to share too, we don't have any 4UP updates, so Soleil won't speak on their behalf today, but she will be sending over a carryover email to the group very soon, so please be on the lookout for that. With the recording, we will send out the slide presentation from today, so you'll have access to that. So please just look for an email within your inbox in the next 5 business days. And we just want to thank the presenters again for this really great information. If anybody has any additional questions, I know that they were offering these up, so please feel free to reach out to them via email, which they will be CC'd on our email as well. If there's any connection that we can help on our behalf, just reach out to us at the SHIP TA inbox, and we'd be happy to connect you as well. With that, we thank you for your attendance today, and we hope you have a great day. Thank you.